So we are just waiting for the participants. We'll let you know once the live starts. Yeah.
Thank you. Busy, Prof, as usual.
Yeah, almost full time. Looks like
Teaching. Yes. Yeah.
Conferences, meetings.
Yeah. Well, you touch wood. You never look tired, though. Yeah. You call yourself as retired, but full time, not tired.
Yeah, I think it's good to be active.
Yes, yes. And I mean, so many people are benefited by your knowledge and experience.
Yeah.
So I think
Yes, we can start now. Yeah.
Great. Hello, everyone. This is Arun, founder of Janitri. We are a Bangalore-based company working on innovations for fetal, maternal, and newborn monitoring devices and solution. We were active a lot in terms of webinar during the COVID session, but now again, I think we have been doing this on a very frequent basis. This time we have come up with a master class on fetal surveillance. And for that session, for the next 2-hour session, we have Sir Dr. Arulkumaran, we have Dr. Latha and Dr. Srimathy, and they're going to take the master class on this. Let me just quickly introduce Janitri, what we do, and quickly introduce Sir and Ma'am. Janitri, established in 2016, working with a vision to see a world where no mother or baby dies during the phase of pregnancy, labor, or post-labor. And we want to make sure that we deliver wearable app plus AI/ML-based solution, which can, so the monitoring can be happen at the right time, at the right place, and early decision can be taken. For this webinar, we have Dr. Arulkumaran sir, we have Latha ma'am, we have Srimathy ma'am, who's going to take you through this whole masterclass on fetal surveillance. So I won't be taking much time and will be straight away handing over to our panelist here. But quickly, let me just tell you, I don't think so all these three needs an introduction, but quickly tell you that Sir Arulkumar is a renowned professor, emeritus at St. John's University of London, with current roles in the University of Nicosia and Imperial London College. He has led the International Federation of OBGYN, authored almost 38 books, published many papers, more than 300. Contribution in medicine, OBGYN is, earned him a Knight, Bachelor's, and other national honor. Welcome, sir. Thank you for accepting our invitation for this webinar. Latha ma'am, Dr. Latha ma'am, based out of Bangalore, is a very distinguished OBGYN here, extensive qualification, including FRCOG from UK, MRCP from Dublin. She's currently serving as the lead OBGYN at Rangadori Memorial Hospital, president at FRCOG Trust, director of WMN Healthcare. And her interest towards technology and impact is truly commendable. Welcome, ma'am. Thank you for accepting this webinar invitation. Dr. Srimathy Raman from done MD, FRCOG, CCD from UK, and consultant at Rangadori Memorial Hospital. She's an MRCOG examiner, top viewer at ICOG Green Journal, and a DNB trainer, ultimately doing a lot of work in the maternal medicine and high-risk pregnancy. And actually won more than 10 gold medal and 13 prizes during her MBBS. So welcome, Dr. Srimathy, for this webinar. And I hope a lot of doctors, nurses, and other people across from the globe can literally be benefited on this particular live webinar. So I hand it over to sir. You can go ahead.
Thank you, Arun. Thank you for organizing for Janitri. And also I'm delighted to participate in this webinar with Latha, whom I have known for a long time, and Srimathy, both illustrious illustrious carriers. And I'll give the brief introduction with nice guidelines and difficulties with interpretation. And I'm sure Latha and Srimathy will continue with the basis of that into case presentations. So I'll share my screen, which I'm sure will come up. Right. Okay. So what we are trying to do is actually to reduce the intrapartum morbidity and mortality. And this is quite an important area because the Sierra region of the WHO, the World Health Organization, says that we contribute something like 1 million or more of stillbirths, of which 50% are due to intrapartum events. And 50% of the neonatal mortality is due to immediate birth asphyxia. But we know that we want to reduce the stillbirth and neonatal death. Then there are a number of attributable causes, not only about deaths, but also cerebral palsy, epilepsy, and learning difficulties. All these follows asphyxial process. But in labor, it's asphyxia is not the only problem, but it could be trauma due to difficult instrumental delivery, infection during the process of labor, or combination of the above. A mother might be in labor, and if she gets pyrexia and then she needs an instrumental delivery, then she has more problems. But there are others which are unexpected. We call the sentinel events, which needs prompt response, like abruption, scar rupture, cord prolapse. So we didn't even think that is likely to happen. But the stillbirths and birth asphyxia related conditions in India, for example, is much less compared to the other countries. Maybe because proportionately, the other causes of chronic hypoxia takes a lead in India. So in summary, monitoring by CTG does not eliminate all cases of birth asphyxia. It will eliminate some, but not all, because sentinel events you can't prevent by CTG monitoring. Of course, it'll help to pick it up early, but it won't completely eliminate the problem. Now, confidential inquiry into stillbirths and deaths in infancy have been going on for a long time in the United Kingdom. This is from a report in deaths looking at 94 to 95. They looked at 873 cases, and 1 in 1,600 births were affected by birth asphyxia. And when the inquiry looked into these babies who are over 1,500 grams, and there were 4 primary reasons why this happened. And inability to interpret the CTG. So that is what we are going to do today. Second, but most important, failure to incorporate the clinical picture. In other words, risk factors like IUGR, preeclampsia, and so on. Third is we identify the problem, but delay in taking action because there is difficulty in getting the theater or the anesthetist. And fourthly, poor communication. These 4 led to the problem. And as you can read from the title, the detailed inquiry said 50% of the cases could have been avoided. Definitely, that's called the grade 3 error. And probably another 25% could have been also avoided. That means in the panel, all were on agreement, 50% could have been avoided by doing a different action, and another 25% maybe. So there is a problem, not only in CTG interpretation, but because of the failure to incorporate the clinical picture, poor communication, delay in taking action. So this is in 1995. Now, the Royal College of Obstetricians and Gynecologists produced a report in 2020, as you can see, and this is each baby count. So this is nearly 25 years later, and they looked at nearly 1,145 cases, of which 859 had severe brain injury. That means HIE grade 3. 165 was early neonatal death. Intrapartum stillbirth was 121, as I mentioned. The proportion is similar, 50% of asphyxia during stillbirth and 50% leads to neonatal death, in addition to severe brain injury. Now, they analyzed these cases in 2020, and they identify 5 factors. And number 1 was CTG and blood sampling, which is fetal blood sampling. So interpretation of CTG was a problem. Second is risk recognition. That is, incorporation of the clinical picture. Third is communication. So those three were identified even in 1995. But they added two other factors. That education and training was an important lagging factor in many cases. That means they didn't have master classes like what we are doing today. So they were employed, but they didn't know how to interpret the CTG. And the next one was individual human factors. Whatever they did, they couldn't understand. So these 5 factors had to be tackled. So CTG reading is not the only issue, but risk recognition, because in some cases of clinical risk factors, the hypoxia ensues within a very short time. And if it is not communicated to the team, then the baby will be affected. So when we talk about risk factors, what are we talking about? Now, we must identify fetal risk factors compared to maternal risk factors. Maternal high risk factors, for example, are preeclampsia, diabetes, previous section, and so forth. But when you see when the mother is admitted to the labor, then you must see whether they are preterm, postterm, growth restricted, thick meconium with scanty fluid, infection, intrapartum bleeding. This might develop during labor or might be present at the onset of labor. Because there are reasons why intrapartum bleeding gives quicker asphyxia than normal well-grown baby. Because with intrapartum bleeding, the placenta is separated, the blood seeps into the myometrium, causes tetanic contraction, and causes more hypoxia. Intrauterine infection, not only because of the metabolic rate is increased, needing more oxygen, but also there are metabolites like tumor necrosing factors, interleukin, and those things aggravate the damage caused by hypoxia on the brain. Thick meconium with scanty fluid, the important is scanty fluid, which means there is some hypoxia and renal vasoconstriction, there's little fluid produced, and the baby passes meconium, it becomes thick pea soup type of meconium. Growth restriction depending on the size of the baby, the size of the placenta, because placenta will be smaller, many cotyledons will be infarcted, and those babies get hypoxia with the same given CTG pattern compared to a well-grown baby at post-term. There is a placental intake of oxygen is much greater, so they also can run into trouble. Preterm, one of the triggering factors infection for preterm, so they can run into difficulty. But also, in addition to the triggering factors, the preterm babies is more vulnerable to hypoxia because it's a more developing brain, so they run into difficulties. Now, what we must remember, it need not be one factor, but 2 factors, post-term and IUGR, or post-term and thick meconium, or post-term and intrauterine infection, IUGR and intrapartum bleeding. So combination of factors may make it worse. So this has to be recognized. But in addition to that, there are iatrogenic factors which can give rise to problems. Those are also fetus at risk. Injudicious use of oxytocin. 2 things to remember about oxytocin. The uterus becomes more and more sensitive to the same dose of oxytocin. So once you titrate a level, then you can't maintain that level. You have to reduce that level once you get more and more contractions. Otherwise, the uterus get hyperstimulated, babies get hypoxic. Second is towards the late first stage, second stage, there is a Ferguson reflex. The head jams into the cervix and the upper vagina, which causes reflex release of oxytocin, more contraction. So there you have to be careful. The second iatrogenic factor is epidural in some cases with compromise. So the baby's heart rate is already abnormal. Then when you're giving epidural, especially in the late first stage, second stage, because when the woman bends to have the epidural, the head jams on the pelvic floor and reduces the blood flow. So you must continuously monitor the baby while administering the epidural, in addition to hypotension caused by epidural. Difficult instrumental delivery, macrosomia, and malpresentation. Macrosomia refers to diabetes and shoulder dystocia. There's delay in delivery, there's a problem. Malpresentation, breech, if there is difficulty in delivery, it causes problem. In instrumental delivery, if you put a malapplication, not in the flexion point, and pull a larger diameter of the head, then the babies can get hypoxia and asphyxiated. And as I mentioned, sentinel events, cord prolapse, abruption, scar rupture has to be watched. Those are risk factors. And on admission, we have to ask for fetal movement from the mother and do an auscultation to listen to a fetal heart rate acceleration. That's what we call as an admission test, asking the mother for fetal movements and listening to heart rate acceleration. Now, if there is acceleration and fetal movements, that on admission, the baby will not get hypoxia in the next few hours of labor. And you can intermittently auscultate after every contraction and identify the decelerations and then act accordingly. Now, I mentioned the previously existing preterm, postterm can be mixed with iatrogenic with oxytocin. So a postterm with meconium, if she gets oxytocin, she is more likely to run into problem. Or postterm with meconium as an instrument of delivery. So these are important risk factors, which was mentioned in the 1995 Kester report, as well as the 2020 college report on each baby counts. Now, the fact that some babies develop acidosis quickly is well established, and these are some papers which suggest like growth restriction. And similarly, there are papers on postterm, preterm. The babies will get more rapidly acidotic compared to the others, so we have to take the action much earlier. So the whole crux of the matter is intrapartum fetal surveillance. Is fetal reserve is the main issue during labor, and many instances of distress are iatrogenic. We cause the distress by giving oxytocin too much. So the monitoring needs to be adjusted for each individual labor, and the NICE recommends intermittent auscultation for low-risk labor and electronic fetal monitoring for high-risk labor, and has provided some guidelines. So that is what we are going to look at, and I'm going to show some traces which complicates how to interpret it and how do we really interpret the actual individual factors. So individual characteristics and all characteristics combined, we must study that well so that we can give the best to the mother. So we look at the baseline rate, and it says determine the baseline rate, the excluding accelerations and decelerations over a 10 minutes period when the fetal heart rate is stable. When deciding if there is any change in the baseline heart rate, compare it with earlier CTG traces or recordings of fetal heart rate. Use the following to work out the categorization for baseline fetal heart rate. So earlier we used to say green, amber, and red. Now they call it white, amber, and red. White is when the stable baseline is 110 to 160. Amber is there is an increase in baseline by 20 beats or more from the start of labor since the last review an hour ago. Or if instead of a rise in baseline rate, if the actual baseline is 100 to 109 or unable to determine the baseline, then you call it the baseline. So it's a fluctuating baseline. You put it into the amber. But if it is below 100 or above 160, it is called red alert. So this is the characteristics of the baseline. And we will look at some of the features of traces with 100 to 109 and over 160. It continues by saying, when assessing baseline fetal heart rate, differentiate between fetal and maternal heartbeats and take the following into consideration. Baseline usually between 110 to 160. Lower baseline are expected in postterm pregnancy, so like 130, 140, and higher baseline like 160 and 170 in preterm pregnancies. A rise in baseline may represent either infection or hypoxia settling in. So you have to be careful. Another reason is dehydration or maternal anxiety, which can increase the heart rate without decelerations. So although baseline fetal heart rate between 100 to 110 is an amber feature, continue usual care if this has been stable throughout labor and there is normal variability and no variable or late decelerations. So fetal bradycardia has been highlighted as less than 110. We must understand there are reasons which causes the bradycardia, and there are fetal and maternal reasons. Fetal is vagal stimulation. If you apply too much pressure on the head. Local anesthetic drugs, we don't give the baby, but when you give a pudendal block accidentally, the drug goes across to the fetus, then it can reduce. Analgesic drugs like pethidine, Valium can drop it by 5 to 10 beats. And if it is less than 100, you have to suspect hypoxia. There are transient reasons for fetal bradycardia, which are maternal origin, like hypovolemia. The mother bleeds due to placenta previa. She diverts the blood to her system and reduces the blood flow to the uterus. It becomes hypotension. And hypotension during epidural or abnormal uterine activity, which cuts down the blood supply. In other words, by hypovolemia in the mother, hypotension in the mother, abnormal uterine activity, you reduce the blood flow to the uterus, there'll be a transient fetal bradycardia. Now, this is an example of a moderate baseline bradycardia. So if you look at it, it is between 100 to 110, but the accelerations are present, the variability is present, and there are no decelerations despite there are contractions. So this means this baby is not hypoxic because accelerations denote the activity of the somatic nervous system, like baby tossing a ball and playing, and variability like the baby smiling, good sympathetic parasympathetic activity. So this baby cannot be hypoxic. The only thing you have to remember when the heart rate is between 100 to 109 or below 100 is to double check with a maternal pulse saying that you're not recording the maternal heart rate. So there are a number of papers which has been published from America, UK, Sweden, saying moderate baseline bradycardia is nothing to worry about, provided there are accelerations, good variability, and no decelerations. Now, when we look at tachycardia, it's more than 160 according to the NICE guidelines, again, fetal and maternal reasons. Compensatory fetal movements, if the baby is running around, then the baby's heart rate will be greater. And hypovolemia, if there's a vasa previa, the baby bleeds, then you can raise the baseline rate. Increase sympathetic tone. If you make a noise on the maternal abdomen, like an acoustic stimulator, or if you on a examination, when you put a scalp electrode and cause pain, that can increase the heart rate. And obviously hypoxia, gradually the heart rate will go up because of the catecholamine surge, and same with intrauterine infection. Now, maternal reasons, again, maternal fever. If there is maternal fever due to pneumonia or some other upper respiratory infection, that will also increase the baby's heart rate. And increased sympathetic tone in the mother, if she's in pain and anxious, then the baby's heart rate, because of the catecholamine transfer, will cause problems. So if you use drugs like beta-mimetics or atropine, it can push the fetal heart rate up. And dehydration or hypovolemia in the mother. So if you go at 9 o'clock in the morning, baby's heart rate is 130 and 12 o'clock is 160. There are no decelerations, but the heart rate has just risen. Then you have to suspect infection and the possibility of dehydration. So you hydrate her and also give some pain relief. The heart rate will come back to normal. Now, this is a moderate baseline tachycardia. The range is 160 to 180. So although we say, oh, 160, you have to be worried, but provided there are no decelerations and accelerations are present with good variability, there is nothing to worry about this baby. Maybe you can hydrate and the heart rate might come down, but certainly this is not a hypoxic trace because the other features. On the other hand, if the heart rate is very high with maternal fever, then obviously you have to reduce the fever and try to see if she's not going to deliver in a short time, to deliver even by C-section, because doing a scalp blood pH is not going to guarantee they can suddenly collapse. So fever is not a good thing because it has a synergistic effect of releasing interleukin tumor necrosing factor with hypoxia, causing more brain damage. So in summary, moderate baseline bradycardia of 100 to 110 or tachycardia of 160 to 180 is not something to worry about, provided there are accelerations and no abnormal features like deceleration. Now, we have to always think before we monitor by, especially with ultrasound, that we are recording the baby and not the mother. The upper trace gives you the recording of the baby and the lower trace is of the maternal. We have put chest leads, and the mother's heart rate also shows accelerations and good variability. So one has to be always conscious about the fact when you're recording the true fetal heart rate and not the maternal heart rate. This is an ultrasound transducer trace at the beginning. Ultrasound has slipped down because of the extra jelly, and it is latching onto the maternal pulse. So you might not realize that it had gone to the maternal pulse, although the lower rate is 110. So one has to be very careful when you see sudden changes, whether we are recording the mother. Now, there's a problem with this trace to see whether the lower line is the proper baseline or the upper line is the proper baseline. If you take the upper line, then those will be construed as late decelerations. But if you take the lower line, you can consider that as accelerations. And the clue here is to look for fetal movements, because when there's a cluster of fetal movements, the baby has a prolonged acceleration. And if it is tachycardia and late deceleration, the variability will be absent. And here the variability is present at the baseline. So the lower one of 120 is the correct baseline with acceleration. So misidentification. If you think the upper line is the correct 160 and late, you might do an unnecessary cesarean section. Whereas if you know if it is 120 and accelerating up to 160, then you'll be happy with the trace. Some people used to call it pseudo distress pattern, but the key is the baby has no other risk factors and generally it'll be moving. Now, this is a trace I reviewed at 10 o'clock in the night. People are getting worried about the trace in the first half because it is difficult to interpret, but I observed the baby was moving inside the uterus. You can see sometimes the baby's movement when you look at the maternal abdomen. And it was very clear that while we were discussing the case settled down and it shows acceleration. That means the baby is not hypoxic. And this can happen in the antenatal period. As you could see, there's a tachycardia and what they think are decelerations, but really there's a tachycardia because plenty of fetal movements. As you can see at the middle cross, the mother has been marking a lot of fetal movement dots here. So whenever the baby is moving, it can't be hypoxic. So hypoxia doesn't exist when there is plenty of fetal movements. Now, if you get too heart rate, then there is a problem because it could be a heart block, like in antiphospholipid syndrome. You can get the atrial rate at a different rate compared to the ventricular rate. But it could be that the baby is dead and mother's pulses are picked up, and by what we call as electronic window phenomenon, the machine transmits as twice, or it can be a fetal bradycardia, and the low fetal heart rate can be conveyed as a double. So whenever you see two heart rates, then you have to suspect whether the baby is alive, and whether there's a fetal bradycardia, you must listen to the baby or use an ultrasound to verify the fact. This is a very rare case of CTG obtained by a direct ECG or scalp electrode. This is in a renal transplant patient with anti-rejection drugs and beta mimetics for beta blockers for the hypertension, which is contraindicated in pregnancy. And it shows sinus bradycardia, but it shows acceleration. So this baby can be monitored carefully. But beta blockers are contraindicated because that can give rise to problem to the baby or growth restriction and other issues. Now we go to variability defined by the NICE. And these are oscillations of the fetal heart rate, usually 3 to 5 cycles in a minute. And you can measure it by difference in the beats per minute, the highest and the lowest, like a bandwidth. You draw a line at the topmost serrations and the bottommost serrations, and that bandwidth gives you the baseline variability. So, and this should be taken when there are no decelerations or accelerations. If there's an absence of variability, you have to be worried because the sympathetic parasympathetic is the variability. And you have to review the whole clinical picture to see whether you have to expedite delivery. And the recommendations for white, amber, and red, the white is 5 to 25, which is normal. Amber is fewer than 5, between 30 to 50 minutes, and more than 25 beats, which is saltatory pattern, for more than 10 minutes, then you should call it amber. Red, you have to be worried if the reduced variability is more than 50 minutes, or more than 25 minutes, or more than 25 beats for more than 10 minutes. So either reduced variability for 15 minutes or exaggerated variability for 10 minutes, or if it is a sinusoidal pattern. So we'll look into what they really mean by these things and if there is any confusion. Now it goes on to say intermittent periods of reduced variability are normal, especially during periods of sleep or quiescence. Certain medicines as opioids can reduce the variability, but intrapartum risk factors should be carefully reviewed, like look for other features of CTG, like rise in baseline rate, which might be suggestive of sepsis, which can also give rise to reduced variability. And increased variability refers to oscillations more than 25, and short episodes lasting few minutes may indicate worsening fetal condition. Obtain an urgent review. There is an isolated reduction in variability of fewer than 5 beats for more than 30 minutes. Then, when combined with antenatal and intrapartum risk factors, this is associated with an increased risk of adverse neonatal outcomes. So if there is a clinical high risk factors, then you must be alert when there is a reduced variability even for a short time. There's reduction in variability fewer than 5 combined with CTG changes like rise in baseline, then this may be a strong indicator for fetal compromise. So if you get reduction in variability with decelerations and a rise in baseline, so all the features becoming abnormal, then you have to. This is what is meant by quiet episodes and active episodes. So you get a period of accelerations and then period of quiet epoch with reduced variability. So this is called cycling. So if a baby is active and not hypoxic, it should not only show reactivity, 2 accelerations in 15 minutes, but it's also show an active and a quiet epoch. And usually the quiet epochs don't last for more than 40 minutes. And that's why they put the mark as 50 minutes. But it doesn't mean you have to take action. You have to, if the baby has been active segment, then quiet, but it goes for a longer time, 1 hour, 2 hours, but no decelerations, then there is nothing to worry because hypoxia doesn't happen without decelerations. So looking at the previous segment, if there was active segment, then you don't have to worry. If the baby would have been damaged earlier, they might show sporadic acceleration, but not this active quiet epoch. So cycling is important to recognize in a trace. So let us look at reduced variability can be due to physiological, which I have demonstrated now, can be due to hypoxia medication like pethidine, Valium, prematurity because the parasympathetic doesn't mature early, tachycardia, when the heart rate is more than 180, the machine finds it difficult to have good variability, cerebral hemorrhage, fetal malformations, anesthesia, and so on. And that is a picture of reduced 3 to 5, normal 5 to 25, saltatory is exaggerated over 24. I have put an additional trace here calling silent, not to 3. If it is like a pencil line, then it's of major consequence. Like ECG, if it is flat, it's a problem. Similarly, this is a major problem. If it is flat trace, then the baby might be already damaged. This is an example of a saltatory pattern, and especially if it is associated with decelerations, then action should be taken. This is a sinusoidal pattern. This is atypical sinusoidal due to acute fetal maternal hemorrhage, and typical, which is a steady baseline with the sinus waveform, is due to anemia, chronic anemia like disease and so on. Now, there could be artificial variability like Pickett's fetal artifact, as you can see in the first half of the trace. That is when you use a scalp electrode if it is moving or there's a little blood or mucus. But once you put it on an autocorrelation transducer, it comes back to normal in the second half. So if you use a fetal scalp electrode, you can get artificial variability or Pickett fetal artifact. And if you use a TENS or transcutaneous nerve stimulator, again, it can give artificial variability. As you could see, when we increase the frequency and strength of the TENS machine, it shows Pickett-Vance artifact and finally jams the signals. Now, there is one exception to interpretation of the CTG with reduced variability, that is decelerations, which are shallow, less than 15 beats are ominous. That is also given in the NICE guidelines as we go along later. So if there is absent variability and shallow decelerations, and then that means it is the baby is hypoxic or likely hypoxic. One other thing to remember is if you see there's reduced variability, but the baby is moving, then that might be due to congenital malformation of the baby. Because normally if the baby is moving, as indicated in the musical notes there, that means the baby should show accelerations. If it doesn't show accelerations, but is reduced, then you have to think about chromosomal or anatomical congenital malformation. Now we go to the final section of deceleration. These are transient episodes when the fetal heart rate drops to below 15 beats from the baseline for more than 15 seconds. An exception to this trace will be reduced variability where decelerations may be shallow, which is the example I showed you. I'll show you some more example. When assessing the significance of decelerations, consider their timing, whether they are early, variable, or late, because early is compression of the head, variable, we think it's called compression, late due to reduced placental reserve. And in relation to the peaks of the contraction, you can look at the timing as early, variable, or late. Now you have to notice the duration of the individual decelerations because as hypoxia increases, the depth and duration of the deceleration increases. And whether the heart rate returns to normal and how long they have been present for. So the longer the deceleration, the problem, not only the longer, but the depth is important. Whether they occur in 50% of contraction defined as repetitive. So we call the word repetitive if it is present for more than 50%. If it doesn't come for more than 50%, that means the baby has enough time to recoup itself. And if there is shouldering in the variable decelerations, if it becomes absent, that is of consequence, and also reduction in variability within decelerations. So regard the following as concerning characteristics of variable deceleration: lasting more than 60 seconds, reduced variability within the deceleration, failure to return slowly or takes more time, and loss of the previously present shouldering. So I'll give you some examples of these and describe the decelerations as early variable, late, and not typical. So this is an example of what the NICE guideline says when there's absent variability, shallow deceleration, so ominous. That means the baby is severely hypoxic and the baby's brain is blunted, so it is unable to respond the same way with a bigger deceleration. And these are the characteristics for deceleration. No deceleration so early is white, or variable deceleration not evolving to have concerning characteristics is white. Amber is repetitive variable deceleration. That means every contraction getting for less than 30 minutes, or variable deceleration with concerning characteristics. That means it's a delay or more than 60 beats or absent shouldering. Then if it is even for less than 30 minutes, then of some worry. Then repetitive late decelerations for less than 30 minutes. But if everything is over 30 minutes, then time has taken place for hypoxia to happen. So repetitive decelerations with concerning over 30 minutes, or repetitive late over 30, or single prolonged deceleration lasting more than 3 minutes. So this is early deceleration. As you could see, it's a mirror image of the contraction. I've drawn two parallel lines. These are variable decelerations with the shouldering, as you could see. There are no concerning characteristics. And these are late decelerations. So if you draw a line at the apex of the contraction, the nadir of the decelerations come 20 seconds later. So you can identify them as early, variable, or late. And this picture shows how the trace evolves. The depth and duration of the deceleration increases with hypoxia. The catecholamine surges pushes the heart rate up. So the depth and duration, and interdeceleration intervals becomes less and less and less. So this is the major issue about repetitive decelerations versus decelerations occurring and every other, because the more the baby's at the baseline, it has more time to recoup the oxygen. So here it is repetitive decelerations with increase in depth and duration, reduction in interdeceleration interval, and a rise in baseline rate. Finally, the baseline will be affected. So let us look at these concerning features about variable deceleration. This is variable deceleration with no concerning features because shouldering is present. It is not happening with every contraction, and the variability is good. This is of some concern because it's taking some time to get back to baseline. So recovery is taking time. So variable deceleration is concerned. This is of some concern because there is a variable followed by late deceleration. And this is a concern because the shouldering has become absent, and also there is tachycardia and reduced variability. So variability has to be interpreted with the deceleration. So this is the American classification, as well as from Williams, that despite late deceleration, if the variability is present, the baby is not likely to be hypoxic. But if the decelerations are with absent variability, that's of greater concern, which is the trace in the lower half of the paper. This is very obvious, ominous trace, absent baseline variability, and shallow late deceleration. I mentioned about prolonged decelerations, which is less than 80. The two things we have to remember is reversible and irreversible. Reversible can be due to too many contractions. Irreversible can be cord prolapse, abruption, scar dehiscence, where you have to take the action immediately. So if you take all these pictures together, categorization of the CTG, white is no decelerations or early decelerations or variable deceleration that are not evolving concerning characteristic. That is white. Amber is repetitive variable decelerations with any concerning characteristics which we looked at. And variable deceleration with more than 30 minutes, or repetitive late deceleration is less than 30 minutes. Now, rate this repetitive variable with concerning or late deceleration more than 30 minutes or acute bradycardia, then they are concerned. So you have to take into account the longer and later the individual decelerations, higher the risk of fetal compromise. That means the depth and duration as it increases with a rise in baseline rate causing tachycardia and reduced or increased variability, then you are. So when you look at this trace, it is at 170. Deceleration looks ominous, but the variability is maintained. This one, 170 late deceleration, variability is gradually going off. This one, 170, variability is gone. So this is the worst trace out of the whole lot. And if this is in a clinical scenario, primary gravity 3 centimeters, she has a tachycardia 170, absent variability and deceleration, then she has no chance of delivering normally if you want to avoid hypoxia. And here, 6 centimeters in an nulliparous, the absent variability with decelerations indicates she's not on oxytocin, so she might not last till the end of labor. So Latha and Srimathy are going to take you through some of the issues of how we put this together into 4 categories, how the hypoxia comes in. One is called long-standing or chronic hypoxia, where there is reduced variability with shallow deceleration. This is the first trace, continuation of the trace. It continues, no response of accelerations or good variability, so the baby might be already compromised. Second is where the deceleration starts gradually and goes up and becomes absent variability, which we call gradually developing hypoxia. And the third is subacute hypoxia, where the decelerations are prolonged with very short period. And here the baby can get asphyxiated with 0.01 drop in pH every 2 to 3 minutes. And acute is 0.01 every minute, and the baby can get hypoxic very quickly. So prolonged deceleration, as I mentioned, if it is scar rupture, cord prolapse, or abruption, you have to immediately think of delivery. But there might be reversible causes where you can postural, epidural top-up, you turn the woman, give some hydration, stop the oxytocin, give some tocolytic, that'll help in many ways. Now I'm going to skip through lots of slides because of short of time. And I'm going to go to some important issue and finish this lecture. So management of cases with abnormal traces, you had to carry out urgent obstetric review, take account of the antenatal and intrapartum risk factors, because that's one of the important things. If variable decelerations persist other than CTG chasen, review by the obstetricians, there's a risk of fetal compromise. If variable deceleration with no concerning characteristics and no other CT changes, including no rise in variability observed, be aware these are common and can be normal feature. These are cases sometimes unnecessarily C-section is done. In an uncomplicated labor, you can leave them alone and support the woman by changing position and mobilizing, and she can deliver vaginally without any birth asphyxia. And take into account when categorizing early deceleration, they are common, they are benign, and they won't have reduced variability, and they won't have rise in baseline rate, so you will be able to distinguish that. Now, acceleration is a good thing because that is somatic activity, somatic nervous system activity, and even if reduced variability, if accelerations are present, that's a good feature. So presence of accelerations is somatic nervous system, and it corresponds to fetal movement. And there are a number of studies shows, as you can see, number 3, if there are acceleration, not a single baby is acidotic. But if the baby has tachycardia, variability is reduced, and deceleration, then 55% acidotic. But that's a function of time, and that'll happen. So categorization of CTG finally is as part of the full assessment. And you have to communicate the current CTG very carefully, and you have to think about 4 features to convey contraction, baseline, rate, variability, and deceleration. Accelerations, if they are present, that's a good sign. And I will skip a few things because we must get on to the case presentation. but I will just finish with 3 slides. So please remember what we have discussed so far is accelerations and normal variability are hallmarks of fetal health. That means accelerations are representative of somatic nervous system activity and baseline variability of autonomic nervous system activity. If they are present, then baby is not hypoxic. Periods of decreased variability may represent fetal sleep. As I mentioned, there's an active and a quiet epoch. We call it cycling. That denotes the baby is in good condition. Thirdly, hypoxic fetus may have a normal baseline rate, but reduced variability. So when there's a reduced variability more than 50 minutes, you must look at it. But if there are no decelerations in this piece, then you don't have to worry too much, because it may be that the baby is having a longer sleep phase. Usually, the deceleration comes in when there is hypoxia. Now, in the presence of reduced variability, shallow decelerations less than 15 are ominous, which I showed you some examples. Abruption, cord collapse, and scar rupture can give rise to acute hypoxia, should be suspected clinically. And hypoxia and acidosis may develop faster with abnormal trace in patients with scanty thick meconium, IUGR infection, and those are pre and post-term. That's the second or third slide I showed you about risk factors. And in the preterm, hypoxia and acidosis can aggravate respiratory distress syndrome and may contribute to intraventricular hemorrhage and sequelae warranting early action. So with a preterm, if there is an abnormal trace, don't wait for too long, because the hypoxic trigger can cause problems. It might even cause hyaline membrane disease and cause hypoxia after birth. Hypoxia can be worsened by oxytocin, epidural, and difficult operative delivery. That's one of the iatrogenic risk factors I mentioned. So you have to be careful when you use oxytocin, epidural, and do a difficult operative delivery. And during labor, if deceleration is absent, asphyxia is unlikely. There's nothing called never in medicine. So even without deceleration, asphyxia can settle in, but usually there'll be some decelerations, because asphyxia in labor, either due to cord compression, which should give variable decelerations, or reduced retroplasmal pool of blood, which should give late deceleration. If these are absent, then if the trace is abnormal with only tachycardia and reduced variability, this can be due to drugs, fetal anomaly, or infection, not only hypoxia. So that's my message about CTG interpretation, with nice guidelines and difficulties with the CTG interpretation. Now, the slides I skipped through are details of prolonged deceleration, sinusoidal pattern, non-recognition of maternal heart rate, and so forth. So maybe in another masterclass, we can take that. And I'll hand over the presentation to Latha and Srimathy. And I'm sorry if I have taken too much of your time. Thank you.
Thank you, sir, for this very informative session. So before I hand over to Dr. Latha and Dr. Srimathy, very quickly, I'll just say that ultimately technology have played an important role providing these kind of information and a couple of decades, and how technology can give a lot of information going forward, which ultimately can help doctors to take decision. And considering those challenges, I think we worked on these kind of a solution where ultimately you can get these information from the wireless sensor, automated interpretation and all automatically, and just straight away on your phone, wherever you are sitting in OPD and all, and ultimately helps you in taking those decisions. And considering all these factors, what we say that applying all these guidelines, NICE, FIGO and all part of our software. So these automated interpretation can come into picture and straight away will be helpful for the doctors to take decision, considering the maternal heart rate too. So I would say that yes, technology is evolving and have played an important role, will be playing an important role in terms of the helper to a doctor. So yes, I hand over to Dr. Latha and Dr. Srimathy.
Thank you very much, Arun. Wonderful lecture, Prof. as usual and as ever.
Thank you.
Well, we are indeed very privileged to have a real master, real authority, world over, accepted as an authority, Professor Arulkumaran, to discuss and teach us regarding mainly intrapartum CTGs that we are going to present. Probably there would be a couple of cases with antepartum CTG, but most of it would be intrapartum. Srimathy, since you're projecting the slides, can you just go to the next slide, please? The learning objectives are presenting case scenarios so that we can interpret traces in the background of those cases. We would emphasize on the 4 types of hypoxia, how to recognize them, etc. Identifying mothers, that is, we will come to that mnemonic later, and we should not be missing out mothers with mothers. Okay, Prof has already emphasized on that. Resuscitation, intrauterine resuscitation, how important it is. So don't spoil the chance of having a normal delivery without using the spoiled mnemonic. And also importance of cord blood gases, which we don't routinely do, or wherever it is required, we are not doing it very often in India. So with this, probably we'll go to the case presentations. Prof, if that is okay with you?
That's fine. Thank you.
Yeah, thank you.
Thank you, ma'am. Thank you, Arun, and thank you, Professor. It's a real privilege to be presenting the cases to you. So I'm really honored, and I should thank Latha ma'am and Arun for giving me this opportunity. So the first case, she was a primigravida low risk. She presented with ruptured membrane septum. It was a clear LICA, and the maternal observations were normal, and we induced her with MISO. And this was the CTG, which we were obviously happy with. So what we wanted.
Yeah, Prof, can we ask you, if this bishop is just 3 and we are inducing with misoprostol, how frequently, I know you might not be using misoprostol, but during induction, how frequently would you do CTGs if the baby has been found to be happy in the initial phase or at the beginning of induction? If
Yeah.
I'm
Thank you. So normally we do a trace before we start the induction process for 30 to 40 minutes to see an acceleration and good variability. If it is seen within 20 minutes, that's good enough. Otherwise, we continue for 40 minutes. And then we put the medication, whether it's oxytocin, prostaglandin gel, or misoprostol, which, as you say, we don't use it in the UK. The only worry about the drug is whether it can cause a rapid absorption if it is given orally or vaginally. In some cases, the vaginal moisture content, temperature, pH will influence the absorption of the prostaglandin. So because of that, we use it for about 30 to 40 minutes after the insertion if it is vaginal or even oral administration. If there are no contractions, then we just take them out and tell the mother that when she starts contracting to let us know, because without the contraction, she's unlikely to run into trouble. So if she she says she's contracting, then we put the monitor again so we can assess the reflex of the baby to the initial contractions. And for 20, 30 minutes, if there is no problem, then we can do it as intermittent every 2 hours or so.
Thanks, Prof. Because
Ma'am, I wanted to ask one.
Yeah.
Does this frequency change depending upon the background? Because here it was post-dates, Prof, but what if, say, it was an FGR induction, and most probably we are going to use Foley's as only. So do we still have to do some monitoring in between, even if she doesn't have contractions, because we are worried about the baby because of FGR?
Yeah, so the general consensus is actually whenever you're using an oxytocic, whether it's prostaglandin or misoprostol or gel or whatever it is, to have continuous monitoring. But then we take a pragmatic approach, and if it is a high-risk case, like as you mentioned, the severe UGR, then it is reassuring at least to do it at intervals of 1 to 2 hours, depending on how bad the CTG is. The CTG is reactive and there are no contractions for 20 minutes, then you can do it 2 hours later, or else if the contraction starts early. There was a trial done by a chap called Andreas Herbst from Lund in Sweden. He did the intermittent electronic monitoring, but in between he's advocated intermittent auscultation, so his mother can go and move around and have a Doppler or a Doptone or a stethoscope in between, just to make sure there's no, soon after a contraction, no deceleration, then they can mobilize and come back 2 hours later if there's a contraction.
Sure. Thank you. Thank you.
Thank you, Prof.
So this lady, she was induced with a couple of doses of misoprostol. She started having some mild contractions, and on examination, she was noted to be 3 centimeters dilated. And so we ARM'd her, which was clear liquor, and commenced her on syntocinon. And this is what we had, ma'am.
Do you think we should have commenced her on oxytocin, Srimathy?
Ma'am,
Or
because
should
the
we have left her alone?
contraction, when as sir said, syntocinon is probably a pain as well
Yes.
as wound, but here because the contractions were not so strong, and because she was already 3 centimeters dilated, we had ARM'd her, and because she was a primate, we had commenced her on syntocinon. We started her on about 8 drops, which is obviously the low dose regime which we follow. So we started her on the lower dose, and
Yeah.
as soon as it started, about half an hour into it, she had this.
Yeah, probably. Do you think, Prof, commencing oxytocin has caused this?
Yeah, certainly it has, because the general advice is the prostaglandin, and if she's starting contracting, to give 4 to 6 hours before you start an oxytocin, because it has some residual effect. So if you look at the NICE guidelines, it indicates that to give an interval. And because generally we have to think in labor that we should not be in a hurry, because sometimes we think it is slow, we think it is not less than a contraction, and we put that. But medically speaking, by delaying, it doesn't cause much of a problem. But by putting something early, then we can create the problem. So the general, if she starts contracting with prostaglandin, then we don't. Say, for example, you give misoprostol, and if you give it orally, then you give it every 2 hours. If you give vaginal every 4 hours, you have a regime. But when you are given and you want to give the next dose of the meso, but she's contracting, although irregularly, it might be better to withhold it, because if you give on top of it, then they might start hypercontracting. The same principle applies to oxytocin.
Yes. I think this lady was sort of rolling around in pain. Do you think, Srimathy, this is loss of contact, or since there is a suggestion that probably there is compensatory tachycardia, do you think it was a true bradycardia that happened?
So
Or
here,
is it a
ma'am,
doubling effect, or what is it? How do we discuss this? Do you think, yeah, there was hyperstimulation, probably, or was she moving around so much
I think
that
she was moving around, I think, because I don't think she was hyperstimulating, ma'am. She would also been given the bedpan then, so which she was mentioned here. So whether the
yes.
position was altered, but the FH was checked with the the ultrasound, the Doppler, and it was this was actually the fetal heart rate and not the maternal. So obviously we did an abdominal and a vaginal examination because we wanted to know whether there were any acute causes, and so
But
we
it
ruled.
says cytosinon was stopped here.
Yeah,
So
we started doing
probably, yeah, there was some amount, some concern about hyperstimulation. But Prof, do you think this is a compensatory tachycardia that the baby has shown, or do you think there is some doubling because the probe was not properly in place, or how do we differentiate it? Because obviously we don't know whether the bradycardia has continued,
Yeah, so naturally, when there are, as you said, Latha, the Toko contraction curve can change either due to the hyperstimulation or due to alteration in posture or giving a bedpan that can artificially increase the uterine contractility curve. But the fact it is coming with prolonged deceleration without interruption, that must be hyperstimulation with prolonged deceleration. And when it recovers, it has a compensatory tachycardia to 160. Usually, if it is a doubling effect, then it should be exactly doubled. So it should be 160 and 80, but this seems to be about 100. So this looks like following that, there are a couple of variable decelerations. But difficult to determine exactly what it is. It could be doubling or even 75% of the lower heart rate. But I would consider that to be compensatory and continue monitoring.
Yes.
So,
Just stopping this oxytocin, it might take some more time for the baby to recover. Do you think we should have given her terbutaline also?
So
This
if
has gone on for nearly 7-8 minutes, if you can. Yeah. 7,
usually
8,
the
9 minutes. Yes.
yeah, usually benign bradycardia or benign, which means due to hyperstimulation or hypotension, tends to recover. 90% will recover by 6 minutes and 95% will recover by 9 minutes. So which means not back to the baseline, but shows signs of recovery upwards. So on that principle, it seems that recovery is taking place. So there's no need to give tocolytics. Stopping oxytocin would be more than adequate. But one should not start oxytocin again unless it settles back to the normal without deceleration. Then you can think about giving or restarting. So it's actually to give time for the baby to compensate, wash off the carbon dioxide, get the oxygen back, and then to think about relooking at the case.
yeah, so for the
Yes.
lady,
Someone has asked why ARM at 3 centimeters.
because
Okay.
it's part
Yeah.
of induction process, ma'am.
Process.
But
That's
part
it.
of induction process, so that's the reason, because she had already had the
Yeah.
prostaglandins as part of the induction process. So obviously for this lady, we looked at all the position, looked at the blood pressure, and of course whether she had any, sort of immediately before that, whether she had a vaginal examination. This lady did use the bedpan, but she was not vomiting, and she didn't just have an epidural. But these are the usual ones which we want to check for. But of course, we wanted to rule out the irreversible causes which Prof was mentioning. So we did do an abdominal and the vaginal examination, and we actually couldn't see any cord abruption. Of course, uterine rupture is not here because it was not a previous section. And the vaginal examination, she was 5 centimeters dilated.
Prof, can I just ask you, would you have done a vaginal examination? Because there is hyperstimulation. So we have to probably initially stop the oxytocin and manage the hyperstimulation because the baby was she was a low risk mother and obviously there was no bleeding, etc. Would you have done a vaginal examination? With bradycardia, would you recommend that we examine them?
Yeah. So
Vaginas.
in this case, there is a possibility, a very clear possibility, there is a hyperstimulation which has caused the prolonged deceleration. And the incidence of rupture of membranes was some time ago. So I wouldn't have expected cord prolapse as a reason for this problem or an abruption because she will have bleeding and abdominal pain and so on. So I would have assumed that the cause for the prolonged deceleration is hyperstimulation. So I would not worry too much about the vaginal examination at this stage, because sometimes this can prolong the deceleration. So I would rather wait for some time, and once it has settled, then would have done it. There's no harm in doing it, but if you are really wanting to reduce the time it takes to settle back to the normal, then better to avoid it.
So this is what was the continuation. So this is a continuation of the previous one. So we had done a vaginal examination here, and then this is a continuation of the CTG. So we continue to have sort of the baseline running. I mean, this was not a maternal, this was only fetal heart rate, which was confirmed. And this was running, I mean, the previous baseline was, before we started, was running here a bleeding 120 to 130, and then after the brady here, probably had some kind of a compensation kind of a thing, but here,
It took a nosedive again. Yeah. But variability is
variability was good.
well
So,
maintained. What do you think?
The dilemma here, because she was still only 5 centimeters. So,
Yeah. What do we think has happened to this baby, Prof? Because it had good reserves to start off with,
Yeah.
and just some hyperstimulation has it caused so much problems, low risk primary, and otherwise, no bleeding, nothing recognizable.
Yeah. So my concern here is, although Srimathy thinks it's reassures its fetal, I'm more concerned it could be maternal, because usually if it's a fetal heart rate prolonged deceleration, by 9 to 10 minutes, the variability becomes absent. So because the pH reduction is about 0.01 every minute. So by 10 minutes, it would be 10 points down. With further, the previous bradycardia of long deceleration would have caused decline in pH with the current one. So I have a bit of a concern whether it could be fetal or maternal. So I'm putting my bets. If I would have seen the trace without Srimathy telling, I would have said this is maternal. Let us look at the fetal. Obviously, you have to do an ultrasound or double check and so forth. And sometimes the sound of the from the machine will indicate whether it's fetal or maternal.
Yeah, it was checked with Doppler also, and it was found to be fetal. The maternal pulse was around, again, around 80. So what would we do?
Well, if you think it is fetal and you are confirmed it is fetal, then it's better to deliver, because
Yeah.
so that is what
But because we didn't have time to sort of bring in the ultrasound machine, etc., because there was a lot of concern about it. Because in between, it appeared as if it recovered, but we don't know why it behaved like this.
If you are confirmed it's fetal, sooner or later it'll suddenly decompensate. So you have to deliver the baby.
So we did have a category 1 cesarean section, but we did it under spinal, and baby was all right. And unfortunately, I don't have the cord gases with me, but the baby was fine and didn't need any resuscitation and was okay. So maybe whether again goes back to what Prof was saying about whether it was maternal or fetal.
Yeah.
So it was, but I don't think they did a scan. They just confirmed it with the Doppler.
So, if you thought it was maternal, Prof, one is the scan. Anything else that we could do? Of course, if we are monitoring with Gen3, the fetal ECG will be picked up, and maternal ECG will be running also on the trace. So you would probably be better off interpreting it. And even with other CTG machines, which have both fetal and maternal traces, probably that would be one way that this problem might be solved. But anything else?
Electrode, would this be one? We do not have it here in India. It's not easily available, but would this be something which you would need to have considered, Prof?
Yeah, if you have a scalp electrode, then it'll give you the direct ECG signals. Published a paper in 1985. Ingemarsen was the first author with myself and Ratnam. We looked at 33 cases of prolonged deceleration, and by 10 minutes, if the deceleration did not recover, then there is a reduction in variability. So this is over 10 minutes and the variability is present. That's why I'm a little thinking whether it could be maternal, and the fact the baby was in good condition.
Yes,
again,
absolutely, you were right, Prof. Somehow this trace, I think it confused everybody so much, and because the Doppler was also used and it was found to be more fetal, and there was some difference between the maternal and fetal. heart rate and category 1 section. But again, somehow we had the time to give spinal, again, surprises me.
Yeah. So in clinical practice, Latha, at the end of the day, we have to act on the benefit of the doubt sort of thing. So if you have that think it is fetal, then one should go ahead. Because, retrospectively, we can comment, things happened well or didn't
That's
happen.
right. Yeah.
So prospectively, everybody is concerned. But analyzing the trace, we had to learn that so if you get such a trace, then it's likely it's maternal, and we have to readjust the transducer to get the fetal.
Yeah.
So as Prof was telling, this is, if it was actually fetal, then it would have been acute hypoxia and the pH would have dropped 0.01 per minute. So 10 minutes, 7.3 would have come to 7.2 and then another 10 minutes. So they'll probably drop down to 7.1 and the variability should have come down. But yeah, so maybe it was a mistake which we did in retrospect. That's what we were, sort of telling ourselves. So
Yeah.
the pH, just for the sake of others who are listening, so the pH drops by 0.01 every minute if it's an acute hypoxia, where the fetal heart rate is less than 80 beats per minute for more than 3 minutes. And the most important factors which we would need to think about is cord prolapse, abruption, or a uterine rupture, or the reversible one, which is
The
hyperstimulation.
only reversible one.
Yeah.
Okay.
And as Prof again said, 3, 6, 9, 12, 15-minute guidance is what is proposed. By 3 minutes, if it is not recovered, it's abnormal. So we'll have to review the clinical circumstances. And by 6 minutes, 90% would recover if there is no pathology. And 9 minutes, 95% would recover if there is no abnormality. But if it is not recovered by 9 minutes, then that's when we wonder whether there is any background, irreversible cause which is happening. So the recommendation is to move them to theater, commence anesthesia and section by 12 minutes and deliver them by 15 minutes. That's because of the pH dropping 0.01 every minute. By 30 minutes at least, we would have dropped almost 7.2 would have become almost 6.9. So that's the reason we want to deliver them in 15 minutes.
Is it realistic? In many of our setups, this might not be realistic, and maternal safety should not be compromised. But definitely we have to get the baby out at the earliest. But unfortunately, following this or taking this guidance, there have been litigations where they have gone to the court saying that baby was not delivered within 15-20 minutes, even in our country. So it is difficult.
So moving
Any
on.
comments, Prof? Any comments?
Well, it's an interesting thing, Latha. We had to ask the question, where did this 3, 6, 9, 12 minutes came from? And the answer is actually, you had to look at this 1985 paper, which I mentioned, by Ingemarsen was the first author, myself second, and third was Ratnam. So the NICE guidelines and the other literature plucked it from there. The reason why we postulated this 3, 6 minutes is actually while the bradycardia was going on, we did PHs continuously, every minute, every second minute, and noticed that the drop was 0.01. And 25 years later, Professor T.Y. Leung from Hong Kong has indicated the same thing by another research paper. So the point by 9 minutes, if it shows signs of recovery, that means it is not come back to the baseline, but even if it starts climbing up, signs of recovery, then that means the baby will recover. But if it is more than that, then it is going to get acidotic. As Srimathy said, 10 points would have gone by 10 minutes. If you wait for another 10 minutes, it would have gone. So by 30 minutes, if you deliver, nearly half the babies will be severely acidotic. So the 3, 6, 9, 12, 15 minutes is a guide. It's not a rule or something like that. So, obviously, some babies will need earlier delivery, like a scar rupture or an abruption will need earlier delivery compared to cord prolapse or due to hyperstimulation if it is not recovering. So essentially speaking, the number of cases which will cause problems are very few. especially the cord prolapse and scar rupture bradycardia. Because cord prolapse, still there is some circulation going on. Scar rupture, no circulation, because once the baby comes out, the uterus contracts and doesn't give any blood to the retroplacental area. And in abruption, it can be severe abruption with no blood flowing in. So I would think you have to focus, if it is abruption or scar rupture, earliest is the better. But if it is unknown reason, like an occult cord compression or a cord prolapse, then you have more time. But this 369 is just a guide and not a rule.
Arbitrary. Yeah.
So, shall we skip this case and go to the next one? Because again, I think we have reiterated most of the points here.
Yes, I think so.
No, but here I think we wanted to ask Prof one question. Maybe I will present it and quickly wind this case. The 37-weeker IUGR AFI 1.5. She was in Foley and she was 2 to 3 centimeters dilated, and we found this. So we were not sure whether there was, sort of loss of contact with the Doppler. Again, we found the FH was 130, and then we readjusted the transducer and we got this CTG. So the question was what we needed to be doing. Should we be doing an ARM because this has happened, or what should we be doing? Because towards the end of the trace, we did find there was a bit of a tachycardia and the variability going down as well. So with the background of UGR and oligohydramnios, and of course, if we did an ARM and if we find meconium, are we okay to carry on because she's still early on with the background? So this is what we wanted to get Prof's opinion.
Yeah, so looking at the trace, Srimathy, from the before it's a deceleration because it's a continuous line, so it is likely to be deceleration. But prior to and after that, you can see reduced variability and shallow decelerations. So it doesn't look like a good trace to start with, even before the prolonged deceleration started. This is what is meant by reduction of variability with shallow decelerations. And if you had any doubt, the mother would say there is no fetal movement, so the chances are there. And secondly, if you do an ARM before you start giving any induction process, then it might show thick meconium with scanty fluid, so which might reinforce. Look for signs of infection, whether baby is moving or not. And if the cervix is sufficiently dilated, then rupture the membranes to see whether there's thick meconium. And then I would really let her go into labor, but deliver by section.
Yes.
We have great
I think, yes.
We'd have great meconium,
Prof, just in the beginning of trace, after the reduced variability, is there an acceleration? Would you feel that is an acceleration?
No, acceleration should be from the baseline at least 15 beats at term. So this doesn't really qualify for an acceleration.
Yeah.
Right. If the accelerations, the ability will be.
So
yes, Prof. So we actually grade 2 meconium. So we sectioned her, didn't we? Yeah.
Yes. So yes, as Prof already mentioned, we wanted to also bring about this mnemonic mothers. So we need to be careful if there is meconium, oxytocin, or if the mother has temperature paralysis, because it's not just hypoxia, but other cytokines as well, which are going to cause harm. Hyperstimulation, hemorrhage, epidural, rate of progress as well, because slow progress, and if there are multiple V's, chances of infection becoming higher, and scar, previous scar, or any kind of even a hysterotomy or any myomectomy, so any scar on the uterus. And of this bleeding and meconium, we need to be really careful because that is going to compromise the baby.
Yeah, so, and combination of these factors, any of these factors will increase the risk, as Professor had emphasized. Yeah, thanks.
So now moving on, this is another lady, primary 4 centimeters, and she had she was into augmentation. She again, Cinto being the culprit, and this is what we had. So she was spontaneous labor, and then she didn't have much of a contractions, and so syntocinon was started, and then we had kind of an hyperstimulation. We had stopped syntocinon here, and she was 4 centimeters dilated. Membranes were absent because ARM was done before, and it was clear like I noted then. and a bit of a caput and a bit of a mountain was seen here. So the CTG again before this was normal. So we probably think like what has happened in the previous case, hyperstimulation, maybe again secondary to syntocinon, ma'am.
Yeah. No, this was not an FGR.
No, ma'am, this was not an
Yeah,
FG.
this was not an FGR, AGA. Okay. Yeah. Yes. And it was clear liquor.
Yes.
Clear
Before
liquor.
syntocinon was
Yes.
there.
So all these are important. Yeah.
So,
And not post dates. She
no.
was just 39 plus. Yeah. Okay.
So I think this again sort of highlights sort of comments which Prof had made about syntocinon and being very careful because
Yeah.
she had got herself to 4 centimeters. So whether syntocinon was needed, because many a time we are also in a hurry, we do an ARM and then it's like the full works, epidural ARM and syntocinon. So I think it sort of gives
So
us
fetal obstetrician's distress, fetal distress, fetal distress, obstetrician's distress. It goes on and on. Yeah. So anyway.
with this,
Yeah.
I mean, the
So,
question was
Prof, yes. Srimathy, you wanted to say
at least
something.
one.
Yeah. I think something has happened to this baby in the meanwhile. To start off with, were you happy with this baby, Prof? Here.
Well, I think the segment of the trace, I would like to see the previous 10 centimeter segment to see what the baseline was.
Yes. Yeah.
Earlier
It
would indicate
yes.
a good condition, because the trace you are showing before the hyperstimulation, there are 4 contractions within a period of 6 minutes or something. So it
That's
shows
right.
and so it's the trace is due to the use of oxytocin. There's no question about that.
Yes.
If the trace was normal before, then I would wait till the trace recovers back to normal and then think whether the contractions are adequate. If the contractions are adequate, then we don't have to start oxytocin. And if it is not adequate, then we can restart oxytocin so that the baby will be in a better condition. So this is certainly
How long would you wait after ARM for the lady to pick up contractions? Couple of hours or even longer?
2 hours to pick up contractions. So if it is with
2 hours.
that, you start oxytocin. And when you get decelerations, you take the point where the trace became abnormal to the point where the trace becomes normal. If it takes 1 hour, then you give another 1 hour or so with normal. So in other words, the CTG features become normal, but the biochemistry might not be normal. Still, the baby might be a little bit acidotic. So you give more time when it is normal, and then you can, in the meantime, you can look at the contractions again. If it is not adequate, you can restart. So the period you have to wait before restarting oxytocin at the end of this trace is, if it recovers back to normal, is the same. So in other words, if it has taken 10, I'm going by the squares, I'm thinking 3, 4, 6, 8, 9, about 10. So about 30, 40 minutes it has taken to get back to the baseline without deceleration. So hopefully it ended up at that point. I would give another 30 to 40 minutes and then look at the contractions. If it is not adequate, restarting.
So this trace is not settling down even after stopping the oxytocin. So at what point would you consider terbutaline, Prof? Because it's progressively worsening.
Because this trace, we are really worried, isn't it?
Worried. Yeah.
At least for us, it's worrying, though it is because of hyperstimulation when we are in the
yes, but it's just not settling.
Yeah, so terbutaline
Iatrogenic problem, but sorry.
Terbutaline is given when you think that you have to do a delivery, but you have difficulty in doing the delivery because of theater, anesthetist, and so on. Looking at this trace, it is settling down to some degree in the sense that you look at the baseline rate, it is settling down to 1. It is not going up or down any further. The variability is slightly improving. And what you are really going to look at is actually to see whether it'll settle down, is whether the depth and duration of the deceleration, whether it's becoming less and less and less, and the interdeceleration interval getting more. So I get an impression that where the point is at the moment, that interdeceleration interval is longer than the ones before. And so if the interdeceleration interval is getting longer and the depth and duration of the deceleration is getting shorter, then it's likely that the trace will recover. So it looks abnormal or pathological, but the subtle signs are the interdeceleration interval and the depth and duration of. So if depth and duration.
So how long would you wait?
Would you be worried about the rise in baseline, and maybe it is not, I mean, with the reduced variability, there is some rise in baseline and with reduced variability, Prof.
Yeah,
Would you agree with that?
Yeah, it has, Latha, as you say, from 148 to 150 or something by 10 beats. Very beginning. But then the heart rate won't come back to normal unless the baby gets rid of the hypoxic changes it has encountered. So I would just wait for a little bit longer to see whether, because the fact that interdeceleration interval is getting longer means the baby has more time to oxygenate itself.
Yeah. Can we sort of err on the other side, give terbutaline if the trace is not settling within 10 to 15 minutes? Yeah.
I can't see the contraction belt is taken off. So
unfortunately, yeah, because probably she was in pain or whatever. It has been taken off, unfortunately. Yeah.
So when you think about terbutaline, you look at both aspects, the CTG and the contractility. If the contractility is continuing like that, then terbutaline would be useful. The reason why I think the contractility is continuing on the same frequency is with each deceleration that must be following a contraction. Deceleration doesn't start. So the deceleration within 3 minutes is 2 decelerations appearing within 3 minutes, that segment, the darker lines, trace. So 3 decelerations means 3 contractions at the bottom. So in 9 minutes, we are talking about 2 to 3 contractions, about 6 to 7 contractions in 10 minutes. So probably terbutaline would be useful, but the encounter would be better if the contractions were recorded so that you can reason out why.
Yes. Yeah. Okay. I think intrauterine resuscitation is very important.
Yeah.
You want to go to the next slide, Srimathy?
Yes, and I just wanted to ask, how long can we wait? I mean, is there a maximum like 15 minutes, 20 minutes? Because, I mean, I know there is some signs of settling here, but if it continues like this, so how long can we wait safely before doing terbutaline or even planning delivery?
No, I think you can wait any length of time. It might take you, usually the residual effect of oxytocin takes up to 45 minutes to an hour. Although the half-life is about 24 minutes. It takes. So you can wait, but I think you have to reassure yourself the contractions are getting more
spaced out.
Spaced out, absolutely. And also there's more interdeceleration interval. And there is no further rise in baseline rate. So you have to combine all this. But if you have any doubts, then it's better to give terbutaline. And if you want to give it, the NICE recommends subcutaneous terbutaline. And if you have acute conditions, you can give intravenous slowly. Using it as a nebulizer doesn't work. So you have to give it either subcutaneously or slow intravenous. So there's no harm in giving, but from looking at the pattern, it looks she's still contracting a little bit more frequently. And you have more time. And if people are concerned, then they can give terbutaline. Certainly, there's no indication to deliver.
Thank you, Prof. So,
of course, you have to make sure that the mother is well, and vagina examination if there are acute events, to exclude acute events. And also, the spoiled mnemonic is very important for intrauterine resuscitation. Stop oxytocin, reduce oxytocin, or stop oxytocin. Sorry, Prof, can I ask you, can we reduce the oxytocin, or you want us to stop the oxytocin when there is hyperstimulation sort of picture?
Principle is 2 principles to observe. One is if there are decelerations of any sort, then it is better to stop the oxytocin. The fetal heart rate responds only with a tachycardia. Sometimes it doesn't decelerate, but it becomes tachycardic. Then you can reduce the oxytocin. So either it becomes a decelerated trace or a tachycardic trace. If it is tachycardic trace with no deceleration, you can reduce the oxytocin. You try to respond by increasing the heartbeat, then you can reduce it by half. But if it is decelerative, then the longer the baby is below the water level sort of thing, the more it is under the deceleration curve, the hypoxia increases. So you're better to stop it.
This thing is position. I think the mother should not be flat on her back to avoid vena cable, aortic cable compression. Please put her in lateral position. People keep saying left lateral position. What's your opinion on that?
Okay. So there have been studies done by an anesthetist called Kinsella, who was working at Queen Charlotte's Hospital. So what he did was actually to put the probes to measure blood pressure on the toes as well as on the fingers. And then when he put on the left lateral, there is the toe blood pressure was much higher compared to what is on the right side. And it is more evident when there is a contraction, because the contraction causes the uterus to stand out anteroposteriorly. So if you're lying down, if she contracts anteroposteriorly, the uterus expands, and therefore the fundus of the uterus, the aorta and the vena cava gets compressed, not anywhere else in the uterus, but the fundus. If we put it on the left side, the mother, then the blood pressure comes normal, like the upper digital blood pressures, finger and the toes are same, when there are no contraction on the left side, or when there's a contraction. But if you put it on the right side, we put the mother on the right side, then there's a decreased blood pressure reading on the toes at the time of contraction, because the uterine fundus compressed on the vessel. So left side is proven to something that is better for the baby.
Thank you, Prof. Yeah, oxygen only if mother is hypoxic or only before anesthesia. Oxygen, giving mother oxygen, it's a very common practice in India. Whenever there is some fetal hypoxia, they think mother is also hypoxic and administer oxygen. Probably it would be more detrimental if we administered oxygen. Would you agree with that, Prof?
Yeah, that's correct, because so much so that even neonatal resuscitation, if it needs prolonged resuscitation, people prefer air rather than oxygen, because oxygen for a longer time dissolves. Transferably, it increases the oxygen to the tissues. But when you give it for a long time, it can form free radicals. And during hypoxia, there are two types of injury due to lack of oxygen initially. And then there's a thing called a reperfusion injury. That is when the blood supply comes back to normal. At that stage, the free radical causes brain vacuolation and so on in the animal experiment. So giving oxygen by mask or nasal prong for a long time is not advisable in pregnancy. But for a short time, then that's fine.
Yeah, IV fluid bolus to improve perfusion. And even if there is no hypertension, post-epidural, probably IV fluid bolus would be recommended, would you say, Prof?
Yeah, it seems to improve the circulation better.
Sorry, sir? Sorry, sir?
It improves the circulation to the placenta.
Yes. Yeah. So, vasopressors, we are not, I mean, as obstetricians, we don't give vasopressors that easily. I think we should consider it. Definitely tocolysis, discontinue oxytocin, and tocolysis terbutaline is the drug of choice in many parts of India. Terbutaline is not available, but it's available on bulk order from a company in Chennai. So that's what I would like to say. Intrauterine resuscitation is a bit, intrauterine resuscitation is a very important. Sorry.
No, my 0.5 ml, 250 micrograms subcutaneously, because I think that would be safer, though IV was possible, as Sir said, but I think we use 250 micrograms subcutaneously.
Yes. Yeah, very much. I think intrauterine resuscitation is very important. And even if we are pushing her to do, pushing her to theater, I think this resuscitation measures should be continued to have better outcome. So, and any of these interventions that we take or undertake, the results should be visible within 30 minutes. Of course, depends on what is happening with the mother and what's happening with the baby. So, next slide.
Here, we just wanted to say it could be evolving hypoxia, though it is because of the hyperstimulation, because here we had decelerations, accelerations going like the stress to distress and distress to death patterns is what we had in our patient as well. Though the cause was because of hyperstimulation, if we do not correct it, then this could be, sort of detrimental to the baby. So that is why identifying is important. And of course, doing all the corrective measures as was discussed. So stress pattern, stress to distress, and then the distress to death pattern. And this can actually progress and evolve pretty rapidly as well. As we saw in this case, though it is sort of settling in towards the end because we've started doing resuscitative measures. So appropriate identification and putting in actions become important. So shall we go to the next case, ma'am?
Yeah. Would you like to say anything regarding stress to distress, distress to death pattern, how to identify?
Yeah, that's in a gradually developing hypoxia. That takes a long time.
Mm.
You find the heart rate, as Srimathy was saying, the heart rate starts going up and up and up. Then the duration of the deceleration increases, the interdeceleration interval gets shorter and shorter, and the variability gets absent. Then once the variability becomes absent, within 1 to 2 hours, the acidosis will set in. So you have to do some corrective measures by that time or deliver one of the two.
So we
Yeah,
moved
thanks.
case,
Yeah.
private gravida, 36 weeks. She did not, she came in because she was having diminished fetal movements. She was not in labor. And this was a CTG which we had. So this is about 10, 30, 40 minutes of CTG. She was otherwise low risk. Her previous scan was a TIFA, and there were no major concerns with her apart from her presentation because she had diminished fetal movements. And there was no history of any other, sort of trauma, injury, or nothing antecedent which she could report apart from diminished fetal movements. And this was a CTG which we had at presentation. So obviously we were a bit concerned, yeah, because it sort of appeared
sinusoidal pattern.
And as Prof said, beyond 10 minutes as well, because almost 10, 20 coming up to 30 minutes. So we were a bit concerned about this lady. So
quite concerned.
Yeah.
Prof, can I just ask you, this has gone on for nearly 30, 40 minutes. What action, if you had seen this trace, what action would you have taken? Would you have subjected her to bedside scan immediately? Because this sinusoidal pattern, which has been going on like this without any maternal or fetal risk, is very worrying with no fetal movements. Or would you have straight away sectioned her? What decision would you have taken?
So this looks more like what we tend to call a sinusoidal-like or pseudosinusoidal pattern, which is a V-shaped rather than a U-shaped sinus wave. And there is occasional shallow deceleration on the trace with some tachycardia. I think she's heart rate is about 150, 160, 150. I can't see the line. So one of the things which presents like this with absent fetal movements is fetal-maternal transfusion. So with the fetal anemia. So I would think that ultrasound and looking at middle cerebral artery velocity would be useful. And if she has no ultrasound scan to be done, then you just, without Doppler, you can look at the Lyco volume and see whether there are any other changes and whether the baby shows any movements. And if you observe and there are no movements on the ultrasound scan, that means the baby is either anemic or severely hypoxic of some form. And then you would tend to deliver her because of absent fetal movements, sinusoidal-like pattern, and no ultrasound observation of fetal movements for 30 minutes. or if the Doppler shows high velocity and the middle cerebral, then it's very clear. Of course, if you have laboratory facilities, you can do a Kleihauer-Betke test on maternal blood, which will again consider. So it's very characteristics of a fetal anemia.
Yes, Prof. So that's what happened. We
Yes.
wanted to do a scan, but we were a bit constrained doing a MCA PSV. So overall, looking at how the trace progressed, we were concerned. So we did do a emergency section. The baby came flat and the hemoglobin was 3 grams. I mean, Kleihauer-Betke is not available so easily here. In fact, the turnaround time is more than 24 hours.
24 hours.
Sent it retrospectively for the baby because when the baby's hemoglobin came as 3 grams, they did transfuse the baby and they evaluated the baby for possible hemolytic anemia. We sent for atypical antibodies and also we sent for the Kleihauer-Betke, and we did get the Kleihauer-Betke positive as 200 ml positive.
Prof, would you have intervened earlier, even if, I mean, if the scan was not available with this sort of sinusoidal pattern, which has gone on for nearly 1.5 hours, at 36 weeks to jump and deliver her was a bit of an issue. There was a lot of debate going on. Well, what would you have done if you didn't have a scan? When would you have intervened with this lady?
Well, I'm familiar with the pattern, so by looking at it straight away,
Yes.
sinusoidal pattern, it's fetal anemia. But usually the woman comes with absent fetal movement. So this is the trace. And at 36 weeks, you should see the opposite spectrum of the trace. You must see a reactive trace with good variability and so on. So there is some pathology going on, and most likely pathology is anemia. So I would have taken a step and delivered a maybe familiarity trace and so on.
Would it have made a difference if we had delivered her probably an hour earlier?
No, I think if she was not in labor, then it is unlikely to cause any difference because it has been for some time. But once the contraction starts, then the problem starts because then it is not only the anemia, but it's cutting down the blood supply. So delay by half an hour now is not going to make much of a materialistic difference unless she is actively bleeding into the maternal circulation. So in medical legal parlance, they will always argue that you should have done earlier because she would not have lost, because 200 ml is really almost like 2/3 of a blood volume, which is corresponding. So if they intervened early, then maybe the hemoglobin would have been 6 grams or 9 grams for the baby, and it would not have the hypoxia, because the follow-up might indicate the baby's brain damage to have some problem. If we intervene early at 9 grams hemoglobin, then the baby would have been in a better state.
So, unfortunately, we don't have a cord blood gases on this lady. What would you have expected, Prof? Hypoxia, acidosis?
Yeah, so the cord blood might have shown some acidosis, but not necessarily acidosis. So I'm sure this baby, if the baby would have been born earlier, certainly it would have been in slightly better condition, but I doubt it very much whether it would have made a lot of difference. I mean, if you ask, if you would have suspected at 30 minutes whether we should have done one, is yes. At 1 hour, yes. 1.5 hours, yes. So at any interval. But once you see such traces and identify the cases, then you won't miss them again. You will always do them. The absent fetal movement.
I think there was a message from Arun, Roshni, saying that there would be some time for question answers because we are running late and we have too much to learn from you and too many cases still pending. But I think we should give an opportunity for the audience to ask you questions if that is okay with you, Prof.
That's fine. Thank you.
Thanks.
Shall I stop, ma'am, and then we can ask?
I think so, Roshni. Arun, do you think we should?
Lots of cases, ma'am. So I don't think we'll be able.
We have quite a few cases actually. Yeah.
Yeah. So there are a couple of questions. Dr. Sucheta is asking, do we get terbutaline in India?
Yes.
We do get it, yeah, from a company in Chennai. But it's a bulk order because they can't sort of manufacture it unless it's a bulk order, I believe. So we have to buy around 1,000 ampules. Isn't it, Srimathy? Something
Yes.
like that.
They want us a
Yeah,
bulk.
and
We buy
yeah,
it and then we give it to everybody because the expiry becomes
yeah,
very, sort of
yeah,
difficult to stock it.
yeah.
Is amazing.
The shelf expiry is hardly 12 months. So the whole of Bangalore sort of um, buys it from one of the centers, from our center.
Dr. Gauri Karandikar is asking, can you explain once why oxygen administration is to be done only before anesthesia?
Yeah.
Prof,
So
explain.
the oxygen is for the mother because the oxygen administration, what it does is actually increases the dissolved oxygen in the blood, the oxygen saturation. What that does is actually allows the oxygen to be disseminated to the tissues much easier. So usually if you are going to take the mother under general anesthetic and even under spinal, if there is a need for general anesthetic, if there's a temporary period of lack of oxygen, difficulty of intubation, which is not that uncommon with general anesthetic in pregnant mothers, then she will withstand. So that's the reason why pre-oxygenation of the mother is advised in before a C-section. In terms of the fetus, it gets a little benefit by oxygen saturation going up. Now, oxygen concentration, which is SaO2, is different from oxygen saturation, which is dissolved blood. SaO2 is really depending on the hemoglobin, so two are a little bit different. The reason why it is not advised to give prolonged oxygen in terms of query fetal distress is because it gets dissolved and it also forms what we call as free radicals in like hydrogen peroxide. So that can cause damage to the baby. So because to reduce free radical release, we don't administer oxygen for mothers in pregnancy for a long time. But for short periods before anesthesia, it helps the mother and helps the baby a little bit, not so much as we expect.
Got it. So which
And most of the time, there won't be maternal hypoxia when there is, yeah. If there is maternal hypoxia due to any other reasons, probably, I mean, oxygen should be administered. But just for some CTG abnormalities, we shouldn't be.
Got it. Which tocolytic to give in case there is an hyperstimulation?
I think we discussed that, terbutaline, and obviously there are a few more options as well, which Sir did come up with. But the most easiest one is 250 micrograms, which is available as we discussed. I think, but this question is interesting because they're asking about isoxaspirin. Is isoxaspirin an option in case of unavailability of terbutaline, Prof?
I haven't used the drug, but it is not studied very much in acute tocolysis. The one that has been used is terbutaline or salbutamol, which is in a milligram dose. And in Canada, they use glyceryl trinitrate, which you can titrate. The disadvantage of glyceryl trinitrate is the half-life is very short.
Short.
Give it very slowly time. Terbutaline, if you give it intravenously, it'll act for about 17 minutes, about double that time intramuscular subcutaneously. There's a risk if you take the mother for a cesarean section after terbutaline or salbutamol because the uterus might contract so well. So if that postpartum hemorrhage does occur, then they have to reverse the action by propranolol 1 milligram, a beta blocker. But usually by the time you give the terbutaline and take the mother to the theater and so on, that effect would have gone off. And it cannot be utilized by nebulizer or a mask because it gets absorbed in the lungs and it doesn't take into the uterus.
Yeah. When terbutaline was not available intermittently, we have used ritutrine. But again, terbutaline is
The
the best, I feel.
isoxaspirin, they come under the same group.
No, isoxaspirin, I think it is alpha and beta, whereas ritutrine is,
Or atosiban, which can be.
yeah.
Okay.
Atazepam, the action is okay. Yeah, action is quite the rapidity of action, Prof. Yeah, we're okay with that. Yeah.
6 milligrams can be given to stop the contractions, because for preterm labor we start with a bolus dose and then
Yes.
an infusion. But it's expensive, so it's
What about nifedipine?
we haven't
Greetings.
tried that actually. We haven't tried that nifedipine, how quickly the action will come and how much it is to. Somebody has to try it. Terbutaline is very in the 1985 paper. So if you put 1985 Ingemas in American Journal, 2 articles were published, one after the other, on the 15th of December 1985. One was on action of terbutaline on prolonged deceleration. The second one was action of terbutaline on uterine activity. So it came as 2 joint papers.
But I think the problem is it's not easily available here in India, so it makes it a bit difficult.
So the alternative would be hexaprolaline or salbutamol. That is
Even Ritonavir.
Wonderful. I think we have come up to an end in terms of question answer and also all the session. And we are right on time before 4 o'clock India time.
No, that's because Arun's Prof cut many of his slides and we weren't able to do lots of cases. So I think we probably will have to have another session so that, we can hear Prof about the sinusoidal and all the other difficult races.
Yes, we will schedule another session definitely.
We can't have enough of
Prof. Yeah. Yes. It was a great privilege and pleasure, Prof, to interact with you. I'm sure all of us have learned so much from you. We went back to basics. I hope you didn't mind, because we wanted to emphasize and re-emphasize many important aspects of basics. So thank you very much, Prof, for giving us this opportunity and tolerating us. Yeah. So yeah, thank you. Thank you again. And I'm amazed at your memory and also the clarity and the spontaneity of your expression. So I hope we will listen to you for many more decades to come. Thank you.
Thank you very much.
Thank you, everyone. Thank you, Dr. Arul sir, Dr. Latha
Thank you. The whole team, we should thank you. Gynae team, we should thank you. Such wonderful coordination. Thanks for,
Thanks, Roshni, for arranging this.
Thanks, Srimathy, for putting those slides together and presenting it. Thank you.
Thank you, and Arun.
Thank you.
Stay tuned for the next webinar.
Thank you.